So Anna, we are on right now, right?
Absolutely, yes. Our
Yeah.
participants are starting to join us.
Okay, so yeah, I see it's a participants list. Maybe give a few seconds for it to stabilize. Okay, so we'll start now. So good afternoon, good morning, good evening, wherever you are. It's my great pleasure and honor to introduce Professor Shekhar Saxena, who is a professor of practice of global mental health at the Department of Global Health and Population at the Harvard T.H. Chan School of Public Health. He's a psychiatrist by training and was a faculty at AIMS New Delhi before he joined the World Health Organization in Geneva in 1998. From 2010 to 2018, he was the director of the Department of Mental Health and Substance Abuse at the WHO. He has authored more than 300 academic papers and was an editor of the Lancet Commission on Global Mental Health and as well as on the one on sustainable development in 2018. His expertise includes providing evidence-based advice and technical assistance to policymakers, businesses, and civil society on mental health promotion and prevention and management of mental, developmental, neurological, and substance use disorders and suicide, and the suicide prevention. He is a distinguished fellow of the George Institute and is a leading thought leader in the area of global mental health. So over to you, Professor Saxena.
Thank you, Palla, for a very kind introduction. Also, thank you for arranging this session. And I'm really grateful to George Institute for providing a platform for some of these discussions. I will share my screen and present in the next 35 minutes or so some of the information as well as some of my thoughts about what is happening, what needs to happen, and how it can be better. And then I'll, of course, be available for interaction. So feel free to ask questions in the chat and we will come to that. I'll just share the screen. Let me check where I am. I'll just see where my PowerPoint is and try to share that.
Just a small announcement, everyone. Webinar is being recorded and any question and answers are allowed in the Q&A box. Thank you.
Pallab, can you see my screen now?
Absolutely, thank you.
Okay, so sorry about the delay. The topic that has been given to me is global mental health policies and sorry, I think I'll just need one more minute.
Yeah, it was a wrong slide.
Yeah, I'll just need one more minute. So please bear with me.
It would also be wonderful to know a little bit about some of our participants. So feel free to pop in the chat box where you're joining us from in the world today. Thank you. Very happy to have you all with us.
Yeah, now we have.
Sorry, Pal, about that. Can you see my screen
It's
now?
fine. Yeah,
Okay,
it's fine.
so the topic that I'll be talking about is COVID-19 and mental health implications for policy, services, and research. Sorry for putting up the wrong PowerPoint, which was my presentation yesterday somewhere else. And so let's see what the contents of this presentation will be. It's global mental health before COVID-19, because I believe it's very important to think about where we were before COVID began, and then impact of COVID-19 on mental health and its implications for policy, services, and research. And I'll be presenting some information, but also some suggestions for what could be done. Beginning from the basics, let's just recognize that the numbers of people who have or have had mental disorders or neurological or substance use disorders is very large. We are talking about tens and hundreds of millions of people in this world who have, at any point of time, uh, one of those mental or substance use or neurological disorders. For example, more than 300 million people with depression, nearly 300 million with anxiety, and as many as nearly 25 million people with schizophrenia and almost 50 million with bipolar. Dementia is one of those disorders, which obviously is a brain disorder, but it has very major implications for mental health care. And it's nearly 50 million people with dementia, and it's going to increase very rapidly because of the aging society. And the change in the last 15 years or now 20 years has been remarkably rapid. Of course, partly it is because we are more people in the world, but also because of the demographic shift. But there is perhaps some real increase in the incidence as well as prevalence of some of these disorders, not all. And that is again something that is very much to be kept in mind, because COVID might actually have given rise to a much larger increase than was envisaged earlier. Along with the prevalence, there is also the burden that has been calculated by the global burden of disease exercise. And that also shows that the burden is large, but it's also increasing. In the last 25 years, it has increased by nearly 50% in all the regions of the world. So you can see on this chart that the lines are going up almost in all regions. And that is something, again, which is a major concern for people. Even bigger concern is that a large number of these people who have disabilities because of mental substance use and neurological disorders are young adults. They are between the ages of 15 and 35. That's where most of the mental disorders begin and give rise to a large amount of disability at the period of time when these people should be studying, these people should be joining jobs, looking after their families. And at that time, unfortunately for many of them, it's the beginning of the disorder and disability which really affects, in some cases, all through their life. There is, of course, a peak in the older age group, which is again because of dementia and partly because of depression. As the substance use problems go down, it's the neurological problems which come up. In fact, these estimates that I am talking about based on GBD exercise are actually underestimates, because as some of the studies have suggested, a lot of deaths are not accounted for by the GBD exercise because they don't include suicidal deaths as being attributed to the mental, neurological, and substance use disorders, as well as deaths in people with chronic mental disorders who die because of non-communicable diseases, which they would not have got if they were not suffering from a mental disorder. And keeping that in account, the number of deaths actually because of mental disorders and substance use neurological disorders increases markedly. And this map shows you that compared to the original GBD method, if we calculate and include some of these additional deaths, which has been done by Vigo et al. In 2019, I believe, the picture changes quite a bit. And as you can see, in majority of countries, the deaths increase substantially if you start counting that. And the DALYs also increase substantially. So you can see the blue colored countries change into cream colored, yellow colored, and so on, which essentially demonstrates that the DALYs number go up very considerably if you account for these things which are not accounted for by the standard GBD exercise. And so the sum total of that means that there is a large burden, and the resources allocated for mental health conditions is much smaller compared to the overall DALY burden, the disability burden, and the budget. So this slide shows you for low as well as middle and high income countries, the gap between the YLDs, which is the darker colored slides, bars, the lighter colored bars, which are because of DALYs, and the budget, which is much smaller than some of these things indicate. So there is a real gap between what the burden is and what the resources allocated for these conditions is. This is true for national budgets, but it's also true for developmental assistance, which of course accounts for a large percentage of what is available in low and middle income countries. Taking one example, the burden because of HIV is about 81 million DALYs, and the development assistance is 6.8 billion dollars, which is the green bigger circle. And the burden because of mental health is 183 million DALYs, and the actual developmental assistance out of that, and these are 2015 figures, is only 136 million. So you can compare the size of these circles, which demonstrates how much is the discrepancy between the burden and the development assistance for these two conditions. I have nothing against HIV. It does require all the help that can be given, but there is certainly a different equation that is being applied to HIV versus to mental health in as far as the developmental aid is concerned. This translates very clearly into the mental health workforce, which is extremely small in the majority of the regions of the world, except European region, where you can see there are 50 mental health workers for every 100,000 population. The rest of the world has very few. And if you start looking at the Southeast Asia region, which is 2.5, and African region, which is 0.9, these are absolutely insufficient for providing any kind of help for the populations that have these disorders. In addition, many of the people who are trained in some of these poorer resourced regions actually migrate to European regions or American regions, giving rise to a further depletion of the very necessary mental health workforce. These data are from 2017 Atlas of WHO. In fact, in the next couple of months, there will be fresh data based on 2020 exercise, but it seems from the initial results that this situation is actually not changing at all. The result of all of this is that the treatment coverage for mental conditions is extremely poor. This chart, which comes from Thornycroft et al. 2016, shows that minimally adequate treatment, even in high-income countries, is less than 1/4 of all people who have a major depressive disorders. And when it comes down to middle and low-income countries, the percentage is much, much smaller. There's hardly anybody being treated adequately for depressive disorders in low-income countries. That is really extremely sad situation. It's depression, so I'm using the word sad, but still it should be completely unacceptable for the countries not to be treating the vast majority of people who require care and who can be treated with minimally resource intensive treatments. It doesn't require too much money to treat people with depression, but still we are not doing that. And the return on investment of some of these conditions is extremely large, actually. It does make sense to invest into mental health because you get a lot of return. If you start counting the direct as well as indirect cost of depression, this is extremely large. And if you start counting the productivity gain as well as value of health, the returns are extremely good. It's $5 back for every dollar that you invest in the treatment of depression. This is by using the non-patented medicines, which are as effective as anything else, and psychotherapies and psychological interventions delivered by less trained care providers, which I'll talk a little more about a little bit later. So the return on investment is so good. The effectiveness of interventions is well proven, and still we are not doing what we should. In addition, I just want to refer to the fact that human rights abuses are extremely common for people and families who are living with mental disorders, and this is present in low, middle, as well as high income countries. It's a myth to say that human rights abuses are only present in low and middle income countries. They are present everywhere. If you start looking at the prison population within US, a very large percentage of them have actually a mental disorder, and they may not be able to defend themselves, they may not be able to get out, and they are treated worse than many of the mental hospitals that we know a lot more about. So human rights abuses is, again, another reason why we actually should be investing in mental health care, because all countries have signed the Convention on the Rights of People with Disability, and we are not actually honoring that at all. You have given me generously 1 hour for this session, but if you gave me only 5 minutes, I will present 2 slides. One of them is this one. And this is especially very pertinent for the times that we're living with the COVID-19 pandemic. We should not be actually talking about mental health as if it's a mental disorder that we're talking about, which obviously affects a large number of people, as I said earlier. But mental health is actually important for all of us, and it has to be seen as a dimension. Some of us have reasonably good mental health. Some of us have mental distress. Some have mental disorders, and a smaller percentage of people have a stable psychosocial disability. But we all are somewhere on this spectrum. If we have good mental health, we can still promote our mental health and have better mental health. If we have a mental distress, we can go for prevention so that we do not go into a mental disorder. If we have a disorder, we can get treatment and care. And if we have a psychosocial disability, we could strive towards a recovery, as much functional recovery as possible. In fact, this dimensional approach to mental health has been well demonstrated during the COVID period, because most people are moving from left to right. if we were coping very well, we have some problems in coping, like most of us have, in adjusting to working from home, not being able to look after our friends and families, not being able to be with them, a loss of income and other things. If we had a mental distress already before COVID period, then we are very likely to go into a mental disorder. And if we had a disorder, we are likely to go into disability, in fact, increased amount of disability. So during COVID period, all of us are facing more mental health problems than we had earlier. And that actually is very important to consider mental health as a dimension in time, so that we fluctuate in time from left to right, and we can come back to left, so we can still regain our mental health. And that is the consideration that we should have when we are talking about mental health policy, services, and research. It's not about some people who have a mental disorder. It's not about they versus us. It's about all of us that we need to be thinking about. And that leads me to my second most important slide, which is how should mental health services be organized in any community, in any society. At the bottom, there should be self-care and informal community care, which should be available to everybody. It should be available in high volume, and it obviously costs it's a very small amount. Above that is mental health services through primary health care, in general hospitals, in community mental health services, which should be available to everybody who needs it. And at the top, there is the specialist services, including a few mental hospitals which are still there for long-term care, that cost the most and should be available to only a very few people who really need it. The problem with mental health services in most countries is that this pyramid is small. That means we have very few services compared to what we need. And also in many cases lying upside down. That means whatever services are there are in specialist services, and there is very little in primary care, and even a smaller amount in self-care and informal community care. That is something that we need to correct. We need to enlarge the pyramid, and we need to make it lie this way rather than upside down. And this is true for low and middle income countries, which obviously have the largest gap, but it's also true in many high income countries who are developing specialist services and not paying attention to mental health services of primary care, which are much more cost effective and almost as effective for a vast majority of conditions compared to the specialist services. More about that later on. But let me move to the impact of COVID on mental health itself, policy, services, as well as research. And this slide shows you, I don't expect you to read it, a number of papers that have been published. There's a very large amount of literature that is already being published on these situations. I've been part of some of them. I would especially like to mention that mental health is one of the work streams in the Lancet Commission on COVID-19, and a paper which is on the left top part of this slide is during publication, and it should be out very soon. There are also many other papers which have been published, including by colleagues like Pallab from the George Institute, and they really illustrate that a lot is being at least thought about, and a lot needs to be done about the policies, services, and research in the area of mental health. I would like to present the fact that mental health is being affected in view of the dimensional approach that I presented earlier during the COVID time, but also say that the impact of the socioeconomic determinants is much more compared to the disease itself. And here are some examples. There is a marked amount of job and financial insecurity in the majority of countries. Millions of people lost jobs in a country like USA. Tens of millions of people who were migrant labor in a country like India. lost jobs and had to actually go back to their villages. There is stress of working from home. If you're able to retain a job, you're working from home. There is the medical treatment disruptions, the school and college closures, social exclusion and bereavement. A lot of people have lost their colleagues or family members to COVID. Lack of access to food in many cases. The food insecurity has increased a lot, and also increased domestic violence, because in many cases you find yourself locked in with the perpetrator of violence in the same family, and that is really a disaster for many people. And also, lastly, fear of infection and contamination. And all of these socioeconomic and factors give rise to increased sense of loss, which is depression, and increased sense of uncertainty, which is anxiety. And both of these conditions have increased a lot during the COVID time. The effect on income, education, and longevity is illustrated by the UNDP Human Development Index, which for the first time is modeled to decrease a lot after it was started to be calculated in 1990. It's the first time that it is going into negative territory, and by a lot. And that will have a direct impact on the mental health situations within the countries. As I said, mental health is being affected for all of us, but there are certain populations which are more vulnerable. Low income groups, which are present in low income countries, but also in high income countries. Migrant workers, persons living in refugee camps, which is a very large population, almost 50 million people are living in refugee camps. Individuals living in mental hospitals and prisons and other institutions, women who experience domestic violence and abuse, frontline workers. I would especially like to mention that, because a lot of public health workers are finding it extremely difficult to work in very difficult circumstances, and children and young people. Let me just take a minute on two of these populations. One is children and adolescents, who are markedly affected. UNICEF in March 2021 suggested that at least 1 in 7 children and youth have lived under stay-at-home policies for more than 1 year, and putting mental health and well-being at a major risk. And OECD predicted that children missing school for 1 year will expect a 3% loss in their income throughout their lives. So this is really a long-term impact of missing school for a period of time. And school dropouts will rise substantially in low and middle income countries, and these will affect girls more than boys. And this is likely to have a major impact on communities as well as countries as we go forward with this pandemic. Take the other example of a vulnerable population, healthcare providers, which many of you might be. WHO suggested that more than 115,000 healthcare providers have died due to COVID-19, and this certainly is an underestimate. The real numbers might be much, much larger than that. And that gives rise to a sense of anxiety and depression amongst their colleagues if they see somebody dying. Toxic stress, anxiety, and depression are very common amongst healthcare providers, and you can see that amongst your own colleagues. Some suicides amongst healthcare providers have attracted a lot of media attention. There was the suicide by a New York emergency care doctor, and there was another suicide in Delhi, actually, in one of the hospitals by a young person. And of course, these could be just illustrations of a much larger problem that is happening, suicidal attempts as well as actual completed suicide. And burnouts are likely to be very large amongst healthcare providers, especially amongst emergency healthcare providers who are struggling with very little resources in many countries to look after the much increased workload that they are handling. And in some cases, there are reports that the community and health and family members are actually attacking some of the healthcare providers. And that is something that the government of India is very concerned about, is trying to take steps against that. I talked about the increase in anxiety and depression amongst the communities, and I've been part of one of the studies that is analyzing data collected in 28 countries. India is included in that, actually. It's unpublished data so far. And it turns out that there is a marked increase in anxiety and depression. This is self-reported. And the critical finding is that the increase in anxiety and depression is actually much larger amongst the young adults rather than in middle-aged and older population. If you look at the distribution of the age and frequency, the bars are much higher between the ages of 20 and 35, and it actually decreases after that. So while COVID-19 as a disease is affecting much more the older age groups, it's the anxiety and depression which is affecting young adults who are struggling in many cases with the responsibilities that they have in terms of the job, the financial security, working from wherever they are, and as well as looking after children and in sometimes older people within their families. So the anxiety and depression is much, much larger amongst this population. There is also the impact of social isolation and loneliness, which has an impact on mental health, but also on physical health, actually. This study, which was published last year, shows that social connections and social isolation and loneliness, which are actually different, have an impact on social support, and they act as a risk factor with some mediators on the overall health and actually give rise to increased mortality, besides, of course, having an impact on the mental health. And this is another reason why we should be very worried that we do not take the often repeated message of social distancing too seriously. It should be physical distancing and social connectedness, actually, because during these times, we actually need more social connections rather than less. While the needs have increased, the services and access services have gone down, actually. And this rapid assessment done by WHO last year showed that in almost all regions, almost all countries reported one or more mental health, substance use, and neurological services being disrupted. So people could get help earlier, and now they can't, because they can't go to hospital, or the hospital is too busy providing assistance to COVID-19 affected people rather than other people. So this is again another reason for us to be very worried about that. While the needs have increased tremendously, the access to services have actually come down. Let me, in the last 5-7 minutes, talk a little bit about the implications of all of this to policy, services, and research. Perhaps the policy brief published by the United Nations General Secretary is illustrating the need for paying attention to mental health during COVID crisis in a very meaningful manner. It has 3 recommendations: apply a whole of society approach to promote, protect, and care for mental health. In fact, the words promote and protect come before care. And that again speaks about the dimensional approach. It's about all of us rather than about some people who have a disorder. Ensure widespread availability of mental health and psychosocial support for those people who need it, especially useful for mental health at the workplace. And support recovery from COVID-19 for mental health services for the future. Building mental health services of the future should start now. And this is something which is very important. Also, the Mental Health Action Plan of WHO, passed in year 2013. It was for the 8-year duration till 2020, but it has been extended just last month to 2030. And I would like to suggest that if we followed the policy that we had already decided many years back, we would actually be doing very well for the COVID crisis also. The vision of this Mental Health Action Plan is a long one, but I would like you to pay attention to some critical words Mental health should be valued. Mental disorders should be prevented. Human rights should be paid attention to, and health and social care needs to be done in a timely manner to promote recovery. Mind you, here it's talking about health and social care because both of them are equally important. And the result should be participation of all, including people with mental disabilities, in society and at work without stigma and discrimination. So that's the vision that was there in 2013. It's there now. And if we can realize that, we'll be taking good care of the mental health problems during the COVID period. The Mental Health Action Plan of WHO has some cross-cutting principles. It includes universal health coverage, human rights, evidence-based practice, life course approach, multi-sectoral approach, and lastly, but very importantly, empowerment of persons with mental disorders and psychosocial disabilities, which is extremely important. And it has 4 objectives: leadership and governance, mental health and social care services in community-based settings and not in mental hospitals, promotion and prevention, and information systems, evidence, and research for mental health. And there are indicators and targets for each of the objectives, and these are being revised now in 2021. Besides WHO, there is obviously also the UN Sustainable Development Agenda, and promoting mental health and well-being is clearly part of that, explicitly included in 2015, and also strengthening prevention and treatment of substance abuse, as well as achieving universal health coverage. And when we use the word health here, we include mental health as an integral part of that. However, in spite of all of these, WHO's latest data suggests that, and it is based on a response from 130 countries, that national policies and programs are including mental health for taking care of COVID-19, but funding is not being provided. So this is again the result of a rapid assessment. And it seems that countries are paying some attention to these services, mental neurological substance services. They're including it in their plans and policies, but funding actually is not being provided. In fact, funding in many cases is being decreased because the health services are spending a lot of money on looking after people with COVID-19 as well as providing vaccinations. So this is again a matter of great concern that actual funding, which was anyway very small for mental health, is likely to actually go down. The implications of services, I'll come back to the pyramid. If you could just do what we thought we should be doing earlier, we will be doing great. And by spending some resources on self-care, informal community care, and mental health services through primary health care, we will be taking care of all mental health issues, whether because of COVID or otherwise. Pallab and me and Graham Thornycroft wrote a paper last year, which I'm very proud of, which was a roadmap to strengthen global mental health systems to tackle the impact of COVID-19 pandemic. And it has many strategies and programs that could be given. I'm not going to spend too much time on that, but for those of you who might be interested, it might be useful for you to read that. I'll particularly like to mention the task sharing or task shifting element of that pyramid, where non-specialists working in the primary care, and in fact even trained lay workers, could actually deliver not only very critically important care by medicines, those who can prescribe, but even psychological interventions. There are many studies now, and this chart illustrates that the overall effect is much higher than the null effect. And these are coming from various areas and various regions of the world, including from India. And it seems that by this meta-analysis published in 2017, we have very clearly demonstrated that trained non-specialists can deliver psychological interventions, which are extremely important for anxiety and depression and many other mental health conditions. One particular aspect that is quite important during the COVID time, when there are lockdowns and people are not able to access services, is the use of digital technology for mental health care, not only for delivering care, but for improving mental health situations in the communities and countries by screening and diagnosis of mental health condition, which can be very easily done by using digital technology, providing treatment and care for people with mental health conditions. Not everybody can be treated by digital means, but many can be. So this is quite important. But also capacity building for human resources for mental health, because as we discussed earlier, the capacity, the people who are providing mental health care are very few, and more people could be trained. In fact, doctors and nurses can be trained by using digital technology to provide the critically important care to their communities, by strengthening mental health care system, and by public mental health awareness and education in online communities, which can be again done by digital technology, including by social media. These aspects have been very clearly discussed by Nasland et al. In 2017, and I will encourage you to read this article if you're more interested in this area. But just to illustrate that there are still some problems in the public health implications of digital mental health. We are actually in the infancy of using the digital technology for mental health care, and we are making some strides, but there are still challenges. There are too many products. One of the analyses done revealed that there are more than 20,000 apps just focusing on mental health, and the vast majority of them are non-evidence based. So it's very difficult to find out an actual, effective, and useful digital mechanism. There is need for global and national governance, because it seems to be free for all. Anybody could start an app. It requires very little effort to do that, and market it as a mental health app, which is actually not good at all. There needs to be regulatory and quality control, just like there is control for medicines for mental health care. There should be regulatory control on psychological interventions delivered digitally. There is more attention to direct care and less attention to capacity building within the system. There is need for public-private partnership. There is a need for integration with traditional services, because digital mental health cannot be existing in isolation from traditional services, because both of them have to work together. And finally, paying mechanisms need to be developed so that a fair payment can actually be provided for digital mechanisms. For example, if a psychiatrist is treating people by telephonic interviews, there should be a way by which that psychiatrist can be compensated, and insurance should need to cover that. And all of that is very clearly not developed at all in many countries, including USA, but also in parts of middle income countries. And that needs to be developed so that we can optimize the use of some of these recent technological advancements to improve and scale up mental health care. Lastly, implications for research. I believe there is an enormous opportunity for research for mental health during the COVID period. There is certainly increased awareness on mental health issues. The media is full of mental health stories, but also perhaps there is increased funding coming in for mental health research. For example, Wellcome Trust has allocated a very large amount of money for being spent in the next 10 years on mental health. The Human Brain Global Initiative is just coming up, and it has projected to raise $10 billion for mental health and brain research. And these are elements which are going to become operative in the next few months and years, and are extremely timely to give rise to more funding for brain and mental health research. There is a lot of data available in public domain. In fact, COVID period is so data rich, and all of that could be used. An example I will give very quickly. An example of research opportunities, brain research, for example, on long COVID is due. Maybe it has implications for brain functioning by itself and mental health functioning. Mental health research on stress and resilience, the fact that some people are having more difficulties in coping, while some other people are actually coping very well. In fact, sometimes their function is improving during the COVID period, is something that should be researched upon. And as I said earlier, effectiveness of digital interventions and also care delivery by non-specialists and also by lay care providers after some training are areas which are very much ripe for further research. There is possibility for comparative analysis of large data sets. I'm not using the word big data, which is interpreted in a variety of ways. There is a natural experiment going on currently because almost the whole world is affected by COVID and by mental health situations. And there are different infection and death rates over time in different localities, different countries, different communities. There is different severity of COVID-19 related restrictions and lockdowns like school closures, work from home, and different impact on income and job across the world. There is need for a longitudinal study, or many studies actually, on child development, on course of mental disorders and disabilities starting from now, and on the effect of treatment interruptions, which are very clearly affected by COVID period, including by the lockdowns. And all of that needs to be assessed. And perhaps there is need for longitudinal studies to start now so that we can track the effect of these biological as well as psychosocial factors which give rise to impact on our mental health. There is one particular data set which is available publicly, which is called the COVID Stringency Index, initiated by the Oxford University. And I've just given here an example that it has tracked the effect of the lockdowns and closures and other restrictions all over the world over a period of time, starting from early 2020. And this kind of chart can be downloaded by anybody. And here I show the stringency of the restrictions in two countries, US and India, over time. And if we had data on mental health, as it is impacted over time, we can correlate that. And in fact, a group led by the COVID-19 Lancet Commission is actually doing that across many countries. And that can really throw a lot of light on the effect of COVID itself versus the stringency of the restrictions that are being placed. And that eventually, if that research data comes out, that could actually be a major input into the policies of countries. By posing restrictions, they're obviously trying to control the infections and deaths, but they might be actually imposing a lot of burden of mental health on the populations. There has to be a very clear understanding of the benefits and risks for both of them when they start these policies. So this is just one example of how some of these data could actually go as a major input into the policies at a local level as well as at an international level. I would like to end by just saying that there is a huge opportunity for building back better mental health policies, services, and research in every country and internationally. Thank you very much for your attention.
Thank you so much, Professor Saxena, for this wonderful talk. And I will ask everyone to post your questions on your Q&A or chat, and we will be looking at that and asking Professor Saxena to respond to them. So I'll start with one question while everyone is thinking, is that in most countries of the world, at least in LMICs, there are very few mental health resources. So if one were to identify a key strategy that governments need to adopt while addressing mental health in COVID, what would be your recommendation in such a kind of scenario?
Pallab, I think you are actually researching that, so you might be in a better situation to answer that. But from my understanding, the policies and strategies that countries already signed for as a part of the Mental Health Action Plan of WHO need to be very rapidly implemented to make an impact. And I'll just give you the two examples which I already gave in my slides. One is task sharing. To situate that a much larger group of people, professionals as well as non-professionals, are trained to provide the kind of care that is needed by using general doctors, by using nurses, by using trained lay care providers, peer counselors. Those are the people who need to be trained so that they can very clearly expand the care beyond what is available by mental health care providers like psychiatrists and psychologists, and under supervision and under support. The government of India, just to give an example, is trying to establish as a part of the universal health coverage the health and well-being centers. There is a big plan for that. Now, my worry is that those centers will actually become disease centers rather than health and well-being centers. So we need to be really true to ourselves and say these centers should be providing at the community level healthcare, including mental health care, and improve wellness rather than to just take care of the disease, which obviously many people need help in. So those are the kind of strategies that need to be implemented very quickly. And the second, which I would like to mention, is the using the technological advances in a prudent way, not in a free-for-all way, but the governments can actually authorize and use some of the digital mechanisms for training people as well as for delivering care. And those are the two strategies I would very much recommend. And in fact, not only for low and middle income countries, but also for high income countries, where, as I illustrated, the treatment gap is still very high. So I think these should be universally adopted and implemented very clearly and very quickly. Thank you, Pallav.
Thanks. I have a question here, and I'll just scroll it through here. So one question is that you share some alternative mental health approaches to tech-enabled services for vulnerable communities living below poverty line in developing countries? And a related one is your thought if increased utilization of apps and data-driven services pose risk to both providers, consumers of mental health care, providers and consumers of mental health care.
Thank you. Were both very important questions. I think one thing needs to be clear, as I said earlier, that technological and digital mechanisms to improve mental health care is important to implement, but with very clear attention to effectiveness, evidence for them, as well as equity consideration. And it is very likely that the inequities which are already there to a major extent might actually increase because of digital mechanisms, because the people who are better resourced will actually benefit more by that, but then some of the vulnerable population who might have less access to the digital mechanism, not owning a phone, not having internet connectivity and all of that, which actually is increasing quite a lot, but still there are many people who will not have that. So it might benefit those people who are anyway likely to benefit from other services. So that is a danger that we need to keep in mind. But there are solutions which could be applied by strategies to use very innovative methods. And when I use the word digital mechanisms, it doesn't include only internet and website. It could be other mechanisms. It could be use of the traditional media like radio and TV, which have a much better access, and also messages rather than voice activated systems, which could actually be reaching many more people. And there are other methods like having ASHA worker or a community volunteer to actually convene people in the community who don't have access to the digital mechanisms and have implement in a group setting, which has been actually tried in India as well as in Pakistan, so that the reach of the digital mechanisms can increase using very innovative methods. So yes, the danger is there, but innovative methods can actually take care to reach the most vulnerable people who have been already very much deprived of the situation. And I would like to add that using community volunteers and community-based non-governmental organizations, including people who are living with mental health conditions, is actually quite critical for that, because that can be an insurance that they will take care that the benefits of all of these are reaching the most vulnerable people much better than the usual doctors and government officials. So involvement of the community itself is going to be very important to initiate that. Uh, I think, Pallab, there was another element to the question. Can you remind me?
Yeah. If increased utilization of apps and data-driven services pose risk to both providers and consumers of mental
Yes,
health
of
care.
course, and that again has been discussed quite a lot in the literature. That in the initial period of using digital mechanisms, there is a possibility for being biased, because the data that is driving some of these initiatives, including interventions and also the use of artificial intelligence, can actually be biased based on the inputs that are being there for developing some of these programs. I would be actually very honest to say that even WHO's guidelines, MHGAP guidelines, which are being used very widely in more than 100 countries, are based on a lot of research which has come from high income settings rather than low income settings, because simply there is more research there. And that is a potential bias which need to be corrected, but it gets amplified a lot when we are talking about digital mechanisms, because the bias is even much more there. And if you are doing, for example, a suicide prevention program based on big data, who's the person who's more likely to be at risk for dying because of suicide, and using data which is coming from a particular region of the world, it's unlikely to be useful for all other regions unless the data actually comes from these regions. So there is a clear risk of using big data, using evidence which is coming from certain regions, from certain populations, to be used universally. So there has to be a lot of care applied in using stock solutions for all communities and all countries. And that is an alert, which I think I very much agree with.
Next the question is, how do we make a case for a moral imperative for mental health in the face of competing demand on finite resources, especially given that we need to address the issue as of now rather than long term. Long term will be there, but how do we fix the issues right now? Mental health issues.
Public health and public policy decisions are based on a variety of inputs, as all of us know. One of the inputs is the scientific evidence, but there is also other inputs. One of them is the economic loss or economic benefit of interventions. And lastly, there is a case as a moral imperative. So there is the health and disability side, there is the economic side, and there is the moral side. Most policymakers take account of all of these kind of evidences, and that's the way it should be actually. But in many cases, it's the moral imperative which has to be demonstrated very clearly by advocates who are working in that area. And the scientists need also to take into account all of these three factors rather than just focusing on the scientific evidence, because science does not exist in a vacuum, and scientists are also part of the community. So I believe that all of us, whether we are scientists, researchers, healthcare providers, or policy advisors, we also need to take care and take account of all the three kinds of evidences: the scientific evidence, the economic evidence, and the moral evidence. And these need to be taken into account for immediate decisions as well as long-term decisions. And it is very much understandable that saving lives is a moral imperative, but preventing disability and preventing distress is also a moral imperative. And finally, it's for the people who decide to take all of these into consideration. We compete in an environment where there are competing demands, and we can do well to present the evidence as it is there by us, and then hope for the best solutions. So that's something that we need to do now as well as in future. And sometimes there are decisions which are eventually helpful to mental health. Sometimes there are decisions which are not helpful to mental health. But as people working in the overall health area, we need to be true to ourselves and present evidence as we believe should be presented and hope for the best. I think COVID is a very good time to present the evidence based on informed information as much as possible so that correct decisions can be made. And some of the evidence that I have presented, if you start using that, I think we'll make a good effort, and hopefully go for good policy decisions.
Thank you. So I'm just looking at the time. So we are just reaching, that's probably the last question, is that given that there are very few mental health workers who are trained in mental health and governments are not financing mental health, what's the role of civil society in that place?
Great question. Civil society, including non-governmental organizations, philanthropists, as well as all of us, need to actually contribute to improving the mental health situation. And it can be by our skills, or it can be also by financing. I believe that the eventual responsibility for providing all healthcare, including mental health care, rests with the government. But they need help, and NGOs and civil society can definitely provide help in terms of advocacy, in terms of mental health promotion, prevention, and in a few cases, even treatment, because sometimes that is the urgent need. And all of that will supplement the government efforts. So I believe there is a lot of need for that. And I'm aware of many telephone crisis lines and other kinds of attempts by civil society, which is playing a very critical role in many countries, including in India.
So thank you, Dr. Saxena. There are couple of more questions, but it's over time, so we will not take it now, but I'll try and respond to them as we summarize this and put it on our website. The recorded version of this will obviously be there on the website, where we will have more details of it. So thanks again for giving this talk. It was wonderful hearing your thoughts, and hopefully others who are listening in would have gained a lot.
Thank you, Pallav, for inviting me, and I'll be happy to respond to some of the questions which remain unanswered because of time limitation.
Okay, thank you so much.